Welcome to Voices for a Healthy Legacy, where we have discussions about health and wellness with relatable medical professionals in an effort to improve generational health outcomes. I am your host, Dr. Andrea, a board-certified family medicine physician, and today's guest is Dr. LaShelle.
Hello, everybody.
Thank you for joining us today.
I'm so excited to be here.
Thank you. I know you have lots of wonderful things to tell us. So first, start out. Just tell us a little bit about you and who you are.
So I am Dr. LaShelle, and I am a board-certified family medicine physician, and I also have the special certification of diabetology. So I specialize in the management of diabetes. I've been doing this now, I cannot believe, for almost 15 years.
Oh, wow. I didn't realize it had been that long.
Well, at least since graduation from med school.
Right.
Yeah, it's been almost 15 years. So.
Okay. All right. So what led to you becoming a family medicine physician? Kind of briefly tell us about that journey.
So at the age of 2, I myself was diagnosed with type 1 diabetes. And as a young infant, toddler, so to speak, with type 1 diabetes, my early childhood years were spent in the doctor's offices and in the hospital. And they became not just my doctors, but my friends, the people that I thought were really cool. So that was kind of my journey into seeing medicine and seeing primary care firsthand, and knowing that I had that desire to help people through difficult transitions and just making sure that people saw someone that looked like me that they can relate to from a medical perspective as well.
Okay, awesome. So you mentioned that you were diagnosed with diabetes at 2. If you don't mind, can you tell us how your parents found out that you were diabetic? Kind of tell us about that journey, because it's a really interesting story that I don't think a lot of people may experience. So how was that?
Yeah, so when I was diagnosed at the age of 2 in the early 1980s, we're going to leave it at that, okay? The technology as far as diabetes management and even discovering diabetes was still a little antiquated. And so at 2, I was pretty well potty trained at the time and would challenge people around me. I bet you I can't drink that whole gallon of water. And as a 2-year-old, that's pretty impressive.
That's a lot
to see. Absolutely. So all of my family members were like, okay, this is funny that she can drink that much water, but it really became pretty alarming quickly. And I would have accidents, trying to get to the restroom on a 2-year-old bladder with a gallon of water. Things were happening fast. And so we lived with my grandparents at the time, and they had hardwood floors. And my mother recounts the story that the night that I was actually diagnosed, I had obviously had an accident and tried to wipe it up. And just like a cup of spilled juice, her foot stuck to the area where there was urine left behind. And fortunately, that was alarming enough to her that she went to check on me, and I was lethargic. So I had already entered diabetic ketoacidosis and was immediately admitted to the hospital. By the time I got there, the quick finger sticks, and remember this is in the early 80s,
right?
That anything at that time frame that was above 300 registered as high. So immediately it registered as high, and they couldn't even assess at that time frame what my blood sugar was until they did a blood draw. And at that point, I was in the 500 to 600 range.
At 2 years old?
At 2 years old. And anyone that is diagnosed with such a serious diagnosis, no fault of my parents at all, but they remove you from the custody of your parents. So I became a ward of the state until my family was able to master my care of giving a 2.5-year-old injections multiple times a day, how to check blood sugars on these massive glucometers. I mean, it looked like a small iPad at the time. And it took about 6 minutes to get your results back. So in an emergency, it wasn't useful. You just had to go really off of what you saw.
Well, you mentioned that at that time, that you became a warden of the state because of this condition. Like, what was your mom's reaction to this? Because she had no idea. Had she known that you were diabetic, of course she would have gotten treatment, much earlier. So how alarming was this for her to see her firstborn, her 2-year-old baby being taken away because of something that she had absolutely no idea about.
And the fortunate piece is that I was at Norton's Hospital in Louisville, and it was at the Children's Hospital component. So I think that, of course, I don't remember exactly the details of it, but it was almost like I just couldn't leave the hospital. She was able to come freely visit, but she could not take me home.
Okay.
And so, I think that there's still a massive amount of anxiety that goes along with that, to feel like I didn't do anything wrong.
Right.
And I think she loved me, but I'm just kidding.
Right.
But that, she really loved me and wanted to do the best things for me. But the diabetes education at the time, they were really, aggressive at making sure that she was able to learn fast. She had to inject herself. She had to inject oranges and all of that kind of thing to really learn what she needed to know to be able to take me home. And the complicated part is that, insulins of the time, regular and NPH, were not very well suited for somebody that was as tiny as I was at the time. So even with her having the best and trying her hardest, there were still times that it was just like, you're going to end up in the hospital.
Right. So. Right. Okay. So now, you were diagnosed with type 1, correct? So a lot of people don't know the difference between type 1 diabetes and type 2 diabetes. So can you educate us on the difference?
And I love to have those opportunities to educate people on the differences between type 1 and type 2, because I think that there's a lot of myths and thoughts that one is worse than the other. And diabetes is a difficult disease state just across the board, whether it's type 1 or type 2. But the science differences are generally that you see type 1 is generally diagnosed earlier onset. So it used to be called juvenile diabetes.
Right.
So normally people under the age of 30 are more likely to be affected by type 1. Type 2 is normally more in the older generations. We also associate like people that are a little overweight or have, those types of issues as our type 2ers. Type 2 diabetes is more common, but not to say that type 1 isn't common. And the biggest difference is that type 1 is an autoimmune disease that affects the pancreas, and there's a deficiency in the production of insulin. Whereas type 2 is based off of more of a resistance to the insulin that you make. A lot of type 2ers actually make more insulin than they should. It's just not an effective insulin.
Gotcha.
And eventually you can see type 2s become more of a type 1 picture, because if we're resistant to the hormone that we're supposed to be making, or the insulin, then eventually the pancreas kind of slows in its production. So there are still people that are type 2 that require insulin. So that's not the definitive piece. But that's the kind of mainstay.
I know you mentioned that sometimes viruses can trigger someone to have type 1 diabetes, meaning it can, I guess it depends on the severity or just the person and what other like comorbidities they may have going on, that they can actually become a type 1 diabetic.
And more or less that you have to have kind of that 2-hit theory. So you got to have a genetic predisposition.
Okay.
And that is kind of hard to identify, because it's not necessarily that it runs in families. Now, you do see type 1 as a part of a family. I mean, my baby sister is type 1 as well, but it's normally that you have a genetic predisposition and you have some type of viral insult, or something else happens to trigger an autoimmunity.
Okay. So, when COVID was a big thing some years ago, how did you see a lot of people being diagnosed with type 1 diabetes during that time?
Yes, and it was actually kind of interesting because it doesn't fit the typical model. So it was individuals that were a little bit older, that may not have had as much, like just from a risk factor perspective, weren't the people that you would expect to develop type 1. And when I say more, I don't want you to think that like that's everybody.
Right.
But type 1 is probably, and I hate to give any exact statistics, but probably like a 1 in 20,000 chance. So still a pretty rare scenario. And just to say that, throughout my practice, where I'm a diabetes specialist, that I ended up seeing probably 2 to 3 more cases of type 1 in a place that I would not have expected to see it. So not like widespread
Right.
that everybody that got COVID is going to end up with type 1, but it was a significant increase from my perspective of what I saw.
Okay. And since the patients were a little bit older and getting diagnosed with diabetes, you mentioned earlier, a lot of times we think of type 2 with them versus type 1. So in those cases, what kind of made you lean more towards them possibly having type 1 versus type 2? Kind of how did you go about that?
So I'm one that's a little aggressive, I guess, just from my own experience about doing further testing, that most patients that come in that are type 1, I want to know what their insulin making capacity is kind of from the get-go. So generally speaking, looking at a GAD65, which is a specific test that's specific to type 1, looking at their C-peptide levels and just kind of really trying to draw in on what their insulin making capacity is, kind of can lead you down those loopholes.
Gotcha.
The other thing is that, in type 1 diabetes, when you're initially diagnosed, there's that honeymoon phase where oftentimes your pancreas will continue to make insulin and then it stops. Makes insulin and it stops. And so in those individuals, if they were incorrectly diagnosed and given the diagnosis of type 2, we generally offer metformin as the first line therapy. Right. And you'll find that metformin was completely unsuccessful in those type 1ers that are just kind of honeymooning. So anytime that you see somebody that was initially diagnosed that is just doing awful as a type 2 with just the metformin, that can also clue you in on, okay, maybe we need to look deeper, that this person is probably not making insulin at all.
Gotcha. Okay. Is there a certain age that people should start getting their blood sugar checked?
So actually the American Diabetes Association, and this is in regards to type 2, that anybody that is beyond the age of 40 should annually have at least a fasting blood sugar or an A1C. The other thing too is we got to recognize our risk factors, right? Because those of us that have higher risk need to be considering those tests a little bit earlier. And I like to really hone in on the idea of prediabetes and what prediabetes looks like, because a lot of times we'll wait and say, well, I was pre-diabetic. Well, that means that you're already at about a 37% higher chance of developing type 2 diabetes anyway. So let's be on that.
Right.
And prediabetes, from a number perspective, is an A1C that is greater than or is 5.7 to 6.4, or a fasting blood sugar that is greater than 90. Most people don't realize that it's even that tight. The other thing too is if you've had a baby that weighed more than 9 pounds, you're pre-diabetic. If you had gestational diabetes during your pregnancy, you're pre-diabetic. If you were born to a mother that had gestational or any type of diabetes, you are born pre-diabetic. If you've been on any of the atypical antipsychotics, so Seroquels and things like that, you're pre-diabetic. So people don't realize that some of those other things that can kind of get us in there. If you have PCOS, you're pre-diabetic. So all of those are risk factors that put you labeled as a pre-diabetic, that mean we need to really be on top of screening you, whether that means that you're 25 or 30.
Right. So even outside of just the number themselves, just the numbers, just the fact of those things that you just mentioned, that increases your risk. So it technically makes you pre-diabetic just because of those experiences that you've had compared to someone who may have not had that. Wow. A lot of people don't think about that. Okay. So what are some of the symptoms of diabetes that people should look out for? And I know people can have some of these symptoms and they may not necessarily have diabetes. So I don't want people diagnosing themselves.
Go to the doctor.
Right. Go to the doctor to confirm and make sure there's nothing else going on. But what are some symptoms of diabetes that we should kind of make us right?
So the things that, are super concerning from a symptomatic perspective is the frequent urination, the polydipsia, or being very, very thirsty, being very hungry, excessive fatigue, just not wanting to move around and do much. Rapid weight loss can be one of the concerning diagnoses. And remember that these are all things that say that I am depleted of insulin. So 9 times out of 10, and even when I'm talking to my own patients, I like to make sure that we have this discussion that I really don't want you to have symptoms. I want you to be tested annually before a symptom comes, because generally speaking, we don't experience symptoms until our sugars are way out of control. So generally even greater than 10, because it's such a gradual process that you don't feel bad until it's real bad. So, I really am hopeful. I didn't mention like tingling, neuropathy type of symptoms, blurred vision. Those are all things that say that my diabetes is uncontrolled. So really what I would prefer is that patients are coming to see us before they have symptoms, and recognize that after maybe I've been diagnosed with diabetes, if I have those types of symptoms, that something is not okay, that I need to be seen rapidly.
Right. So when should someone, well, first of all, tell us what an endocrinologist is, please. When will someone's doctor recommend that they see an endocrinologist?
So endocrinologists are physicians that specialize in hormones and hormone therapy in general. So they are classically who diabetes management is a major part of what they do. Now, people like myself that have diabetology as a certification don't necessarily treat all of the hormone cascade, but will manage diabetes.
Right.
And I think that it's a very personal experience for anyone. I think that most primary care physicians are able to treat diabetes and can do it well. But if you just find that you're not successfully getting where you need to be from a goal perspective, whatever those goals may be, and that you just don't feel like you are so-called living your best life, if you're not feeling like you're getting what you need, then certainly seeking out the expertise of an endocrinologist, I think, is reasonable. A lot of times, too, we see disease states kind of cluster together. So if you have diabetes and you have thyroid dysfunction and you have, hypogonadism or things like that, then certainly pairing them and having somebody that does all of it may be a reasonable thought.
That's good. So speaking of, different things that they manage, when we're thinking about diabetes, some people just think about the blood sugar part of it. But there are different things that the high blood sugar, or even if you've had it for so long, things we should be concerned about from maybe a heart perspective, kidneys, various things like that. So will you talk about how with diabetes, it's not just quote unquote diabetes, it can be other things?
Absolutely. So in regards to the things that diabetes can further complicate, that you're absolutely correct that cardiovascular health, renovascular health are all things to be really, really concerned about. And, kind of not to be the Debbie Downer, but even individuals that have very well controlled blood sugars are still at risk for cardiovascular disease.
Are there ways to prevent type 1 or type 2 diabetes? Is that a thing?
So prevention, yes, to a certain degree, not the type 1 side, unfortunately, but the type 2 side, lifestyle is a huge part of it. That we can always have that genetic predisposition and, even the pre-diabetic conditions. But generally speaking, if we're overweight, losing 5% of our body weight, which is not generally a lot, is very successful in making sure that we don't go on to develop type 2 diabetes. Gotcha. 150 minutes of exercise per week, following a balanced diet, those are all things that can be helpful and successful in preventing type 2 diabetes. But, I always say, too, that I don't want people to feel like, well, this is all my fault, because sometimes it's just going to happen.
Right.
But those are things that I think that help to prevent and then successfully manage if we get to that point.
Okay. Now, a lot of people want to know or have asked, can I reverse it? Like, we'll specifically talk about type 2. Like, once I get it, can I reverse it, come off all my medications, and have life like it was before I knew I was a diabetic?
This is always a really tough question for me to answer because according to insurance, no. That once you've been diagnosed with type 2 diabetes, that diagnosis stays with you. Can it be completely diet controlled and, that I'm not taking any medications? Absolutely. But the other piece of it too is that, I serve a true and living God. And I think that if he decides that he doesn't want me to be diabetic anymore, that he can certainly make that decision. But I feel like that we just have to live the life consciously and making sure that we're doing the things that we absolutely need to be doing. And I think that now we practice in the golden age of diabetes medications. Right. I mean, right now it's hard to get your hands on some Manjaro, But in addition to that, we know that those medicines not only control diabetes and help with weight loss, but they also really do help to prevent cardiovascular disease. There's a lot of research going into fatty liver or NASH, that those medications treat that we know that it helps to manage our triglycerides. I mean, there's so much that we know that those medications do and safely manage that I'm not so sure that if I was able to be on it, that I would be willing to come off of it, knowing some of the things that it does prevent. So,
gotcha. Okay. So what advice do you want to leave with our audience about building a healthy family legacy?
From my perspective, diabetes is such a massive part of the healthcare scenario, healthcare costs, and all of those types of things. And I feel like that just in regards to those that live with diabetes or know someone that lives with diabetes, that a part of helping in regards to those legacies is it's a big disease, and and take off bites of it, chew off what you can, and work on the rest, and feeling like that, being supportive of people. And I get so frustrated of hearing people do the whole blame game, that this is your fault if you would have lost 10 pounds 5 years ago, or if you didn't eat that honey bun, or, and even policing people that are living with diabetes, don't eat that. You can't eat that.
Right.
They can eat things. It's okay. But that's my biggest part, that, I want to entice people to be able to live a sweet life with diabetes, and that it's okay. And know that you can partner with your physicians, that we're not trying to just fight you. It's okay. We want to work together.
Right.
And you can do it. I'd rather be a cheerleader than a coach, so to speak, when it comes to diabetes management.
Excellent. So if people want to reach out to you, follow you on social media or what have you, where would they be able to find you?
You can find me on Facebook, The Sweet Life with Dr. LaShelle Barmore.
Okay. Awesome. Thank you for tuning in to Voices for a Healthy Legacy. I am your host, Dr. Andrea, and I will see you in the next episode.